coming to the evolution of anticoagulants, it started way back in 1939 with heparin and diconval being the prime agent used as anticoagulant, and it's still under evolvement. So before going into the topic, I'll briefly summarize about the coagulation cascade physiology. The coagulation cascade has three pathways: the intrinsic pathway, the extrinsic pathway, and the common pathway. The intrinsic pathway, it starts with the surface contact, which activates factor 12 to 12A, which in turn activates factor 11 to factor 11A, and which acts upon the factor 9 to get activated into factor 9. And the extrinsic pathway, it is nothing but the tissue damage activation pathway. In this, factor 7 gets activated to 7A, which at last acts on the factor 10 and gets converted into factor 10A. This ultimately results in conversion of prothrombin to thrombin, which acts on the fibrinogen and gets converted into fibrin to form a stable fibrin plot. And now coming to the classification of anticoagulants, based upon the route of administration and the target of action, the anticoagulants are classified into parenteral and oral anticoagulants. And based upon the target, they are classified as direct thrombin inhibitors and factor 10A inhibitors. So the already commonly used anticoagulants are the bivalirudin, argatropin, and heridins. These are the thrombin inhibitors. The heparin and low molecular weight heparin, the thrombin inhibitors, and the fondaparinux, they are factor 10A inhibitors. And others will be the vitamin K anticoagulants like warfarin. So coming to the warfarin, which is vitamin K anticoagulant, the mechanism of action is it acts by inhibiting the vitamin K synthesis by bacteria in the gastrointestinal tract, which is ultimately results in the inhibition of clotting factors like 2, 7, 9, and 10, which depends upon the vitamin K as its cofactor. And the pharmacokinetic, it is metabolized by cytochrome P450 system, and it's used in various conditions like deep venous thrombosis, pulmonary embolism, and atrial fibrillation, and even in coronary artery disease. But the common adverse effects being bleeding, lethargy, there are even the presence of muscle pain, and is contraindicated in pregnancy and patients who are allergic to the drug. So coming to the warfarin reversal agents, warfarin can be reversed with the help of prothrombin complex concentrates or the fresh frozen plasma, and even with oral or IV vitamin K agents. So the limitation of warfarin being, it requires frequent monitoring, which necessitates regular clinic checkup, and it has a narrow therapeutic window. It has low onset and offset of action, which requires almost 5 days to reach the therapeutic level, and it has a longer half-life with numerous drug and dietary interactions and unpredictable pharmacodynamic and pharmacokinetic action. And because of all those effects, they came up with the development of new oral anticoagulant agents. So this is a clinical comparison between warfarin and new oral anticoagulants. So coming to the mechanism of action, warfarin inhibits the vitamin K, which ultimately affects the vitamin K dependent clotting factor, whereas the new oral anticoagulants, they directly act on the target agents like the thrombin or the factor 10A. And warfarin requires regular INR monitoring, whereas no new oral anticoagulant agent, it does not require any routine monitoring such as INR or APTT. And warfarin comes with various drug as well as diet interactions, and new oral anticoagulants, they are free of drug interactions. And there is no specific reversal agents for warfarin, whereas NOACs, they have a specific reversal agent. The onset of warfarin is going to be gradual onset, whereas NOACs, it is rapid onset and offset. And the risk of stroke prevention, it is similar in efficacy of when we compare with both the agent, and the risk of bleeding is higher when it comes to warfarin, and the cost is warfarin is cost effective, that is less expensive when compared to NOACs. So why are we moving towards the new oral anticoagulant? One advantage is the onset of action, which is going to be rapid, as well as rapid offset of action. So this is the clinical profile of the agents which are commonly used. One is the dabigatran, rivaroxaban, apixaban, and edoxaban. The mechanism being the dabigatran, it is direct thrombin inhibitor, whereas rivaroxaban is direct factor 10A inhibitor. Apixaban and edoxaban, are also direct factor 10A inhibitor. And among this, dabigatran is a prodrug, and dabigatran and rivaroxaban, they get absorbed rapidly. And the rivaroxaban, it is 66% of bioavailability when taken with food. The half-life being it around 12 hours for all the drugs, and the protein binding is highest in when it comes to rivaroxaban. And the rivaroxaban and apixaban undergoes liver metabolism, whereas dabigatran it gets excreted through renally, and it has no effect with absorption of food. An effect of body weight, none of the new oral anticoagulant agent has extreme effect on the body weight. And effect on renal impairment, dabigatran should be used with careful monitoring of the patient who are having renal impairment. And the doses being for dabigatran it is 75 mg and 110 mg and 150 mg. And the other three drugs comes in the formulation of 2.5 mg up to 10 mg. And the dosing, the dabigatran requires 2 times a day, whereas the other drugs requires 1 times a day dosing. So those are the indication and doses. The new oral anticoagulant agents are used. They are used as for prevention of atrial fibrillation and venous thromboembolism prophylaxis, etc. So coming to the monitoring specific to the new oral anticoagulant agent, dabigatran, the preferred method being the ECT, that is eccarine clotting time, and the DTT, dilute thrombin time. For rivaroxaban, apixaban, and endoxaban, we can monitor with the help of anti-factor 10A activity. So the specific reversal agents, the idarizumab, it helps in the reversal of dabigatran. The mechanism of action being it binds directly with the dabigatran with high affinity, thereby reversing its action on the target agent. Whereas andexanet alpha, it also binds with the complex formed with the oral anticoagulants. Siraparatog is an reversal agent which acts on all those agents, that is apixaban, argatroban, dabigatran, as well as the fondaparinux, and helps in the reversal of its anticoagulant effect. So the pre and post-operative care when the patient are on new oral anticoagulant. So if the patient is going to schedule for low-risk surgeries, 1 day prior to the surgery and on the day of surgery, the drug should be stopped. If it is going to be a high-risk surgery, 2 days prior to the surgery and 2 days after the surgery, the new oral anticoagulant agent should be discontinued. So, if the patient has uncontrolled or life-threatening bleeding on new oral anticoagulant agent, so we should start with general management. We should collect the type and dose of anticoagulant the patient is on, the last intake or administration when the patient got the last shot of anticoagulant, and baseline monitoring of hemoglobin, platelet count, creatinine, and other coagulation profiles should be noted down. And coming to the general and supportive measures, so we should withhold the next dose of anticoagulant. Hemodynamic support should be provided and transfusion if required. And if it is acute ingestion, we can reverse the patient with charcoal ingestion, or we can consider tranexamic acid. So if we know the type of anticoagulant the patient has taken, we can next go for the laboratory testing. If it is dabigatran, we can check the diluted thrombin time or eccarine clotting time or the plasma drug concentration. And in case of dabigatran, it can be reversed with the help of idarizumab with 5 gram intravenous application. If it is a factor 10A inhibitor, factor 10A level should be assessed and it should be reversed with the help of andexanet alpha with the dose of 400 mg IV. And for factor 11 inhibitors, we should monitor activated prothrombin PTT, and we can reverse with the help of tranexamic acid. So, what are the challenges we face with new oral anticoagulant agent? In spite of its many advantages which it comes with it, there are a few disadvantages. That is, they are not suitable for mechanical heart valve, and it promises only limited use in patient with mitral stenosis and limited use in patient with severe renal or hepatic dysfunction. And there is a high incidence of gastrointestinal bleeding when compared to that of the warfarin, and complex dosing when it comes to obesity, and it has a few drug interaction, and overall it has highest cost and available of reversal agents commonly. So now what is the status of new oral anticoagulants in the year 2025? So those are the agents which is termed as factor 11 inhibitors. They are the antisense oligonucleotide, monoclonal antibodies, and small molecules. So those the trends of new oral anticoagulants. We are moving forward with the development of new oral anticoagulant. So this can be applied in preventing acute coronary syndrome, and it helps in the thromboembolism in CKDs or in carcinoma patient, and it can also help in prevention of non-cardioembolic stroke, and in even in post-operative settings. So those agents are termed as the third generation anticoagulants. They are particularly the factor 11 and factor 12 inhibitors. So the antisense oligonucleotide of factor 11, they are called as the Ionis factor 11. And the monoclonal antibody factors are the osacimab, apilizumab, milvexian are the small molecule inhibitor. And fesomersen, it's an antisense oligonucleotide of factor 11. And asundexian, they are also small molecule inhibitor of factor 11. So the mechanism of action of those agent is targeted towards only two factors, that is either factor 11 or factor 12. And the routine dosing also it requires either subcutaneous or oral or intravenous application, and it requires only weekly or monthly dosing. And it has slow onset, and few drugs have rapid onset of action as well as slow onset of action, and it does not get affected with the renal impairment. So few studies were conducted to know the effect of the new oral anticoagulant in special population like a patient with extreme obesity as well as acute kidney injury. And in all those patients, they concluded that the new oral anticoagulant treatment for prevention of the ischemic events were effective when compared to that of the warfarin. And these are the few trials which supported the use of new oral anticoagulant when compared to that of the warfarin. So the prime trial being the Rely trial, where the dabigatran drug 150 mg dosage was compared to that of the warfarin, and it found to be superior to warfarin in reducing stroke and systemic embolism. In case of Aristotle trial, this demonstrated the comparative study between apizibin, which is a oral 10A anti-10A agent, versus the warfarin, and it also demonstrated superiority of this over the warfarin in patients with AF. And in Rocket AF trial, they studied among the comparison between rivaroxaban versus warfarin. It also proved to be superior. So all these trials supported the use of NOACs when compared to that of the warfarin. So why are we talking more about the anticoagulant market? It is because the Asia Pacific region, we stand among fourth of all the countries in the world of commonly using the anticoagulant agent. And this anticoagulant agent, it growing at a rate of CAGR of 7.5 percentage up to 2025. And because of this importance, the World Health Organization have also added the anticoagulant agent to its list of essential medicines of non-vitamin K anticoagulant in order to prevent non-valvular atrial fibrillation. So now coming to the topic, why do we call this as NOAC, and what does the acronym NOAC stands for? Whether it is novel oral anticoagulant, new oral anticoagulant, non-vitamin K anticoagulant, or does it stands for no oral anticoagulant? So to answer this topic, there were various studies conducted on how to term the oral anticoagulant and what should we call the no oral anticoagulant as. So in this survey, the respondent, they slightly preferred the drug to be addressed as DOACs. About 30% of the consultant, they were in favorable of the term DOAC over the other terms like NOACs, because this was misconstructed as the use of no anticoagulant. So, in order to avoid the confusion, it is always better to term those drugs as DOACs. So, on conclusion, over the past 15 years, the new oral anticoagulants, they are under revolution, and we targeted two things. One is the most advantage of its inhibition of specific target action and in preventing the thrombotic risk as well as while minimizing the bleeding complication when compared to that of the older anticoagulants. So in order to address these gaps, the new anticoagulants are still under development. So those are my references. Thank you.